presentations. Are we ready to go with the case presentations, or are we still uploading them? We have one more. Okay, all right, good. So as while all of you are writing, I hope that everyone found the meat and potatoes of the course to be helpful. What we did a few years ago was to incorporate case presentations kind of along the theme of the why and the how is this necessary in your practice. One of the participants asked me during the session, you know, I've seen some folks kind of score out the hepatic veins and things like that when you're doing a liver resection. You have to do that. You have to do that. So you got to know what your anatomy is and where to go, unless you mark things where they are. My good friend Dr. Ionity, who does a lot of MIS surgery, when he's doing his laparoscopic resections, he's marking where the hepatic veins are coming in, you know, on the liver, so he's prepared for it when he gets to that point. And those are the tributaries, not the main, you know, hepatic vein. But I'm talking about to mark where your resection is. Anybody could do a right and a left hepatectomy, right? What makes you an HPB surgeon is you know all the finesse. Okay, you know how to do segmental resection. You know how to do sectionectomy, and you can do that by using ultrasound. Are we ready?
Yes.
Okay, great. So we have a couple different presentations this afternoon, and then we'll get into a debriefing. So the first presenter, I want to introduce. Some of you already met her, some of you know her, Dr. Erin Baker, who is the program director for the HPB Surgery Fellowship at Atrium Health. She's also the associate PD for the general surgery program, associate professor of surgery at Atrium Health, and she's going to show us some cases on pancreas biliary, you know, all of the above. Thank you, Dr. Baker.
Try to use this for anything.
Okay, it's a little bit loud. Okay. Good morning, everybody. I hope everybody enjoyed the hands-on portion of the course today. I thought that was really great and got a chance to see all different kinds of tips from our excellent faculty who all use ultrasound in practice. So I hope that that really gave you some good ideas of what to do in practice and what to look for, as well as some tips for targeting, which can be very challenging, I know. So Ellen, this is the first time that she has asked me to help do some of these cases today. And I honestly had no idea what to prepare. So I just picked some of my most recent cases to be able to kind of show you guys how I was using ultrasound and trying to help make decisions either intraoperatively or how to try to use this. So this is first patient who came to me. And so she is 57 years old. She showed up in an outside hospital with significant abdominal pain symptoms. And what they did a whole bunch of workup about her kidney because there was some small infarct in her kidney. And what they happened to see as well was that she had this big cyst in her pancreas. So she was really sent to me for a cyst in the pancreas. And I happened to have an old scan. So she had an old scan that was done in 2013. So you can see on her old scan back in 2013, she had kind of a little small cyst in the uncinate process of the pancreas. Not super exciting, maybe a little small side branch IPMN or something like that. But on the newer scans, what I saw was that the cyst had actually really grown and increased in size a lot. So it had gotten quite a bit bigger. Oops, I went back the wrong way. And so what I'm seeing now is that the cystic lesion had actually grown a lot. now the pancreas has some pretty significant pancreas ductal dilation. So the pancreatic duct is about 6 millimeters or so. And she has this big stone that was kind of stuck there right in the front portion of the pancreatic duct. So I sent her for endoscopic ultrasound, yada, yada. We do all of the kind of appropriate things. The cyst was suggestive of a mucinous type lesion. So in my mind, I'm thinking that this is a 57-year-old female who presents with an increasing and enlarging pancreatic cyst. Now on current imaging is causing pancreatic ductal obstruction, has an associated large calcification that they're not able to remove or do anything with. So I counseled this patient regarding certainly risks of a potentially precancerous IPMN. And so we took her to the operating room for a Whipple procedure. Oh, this is the rest of the stuff that I did. I'm sorry. So her CEA was actually, this is serum CEA. CA19-9 was a little bit elevated, I think probably from that big stone that was causing pancreatic ductal obstruction. They ended up not biopsying it, but they looked at it. The EUS findings showed, again, this large calcification, big cystic area. They thought it was a serous cystadenoma, but I wasn't buying that. It didn't look to me like a serous cystadenoma. Plus that we had these kind of 2 scans over time. So we knew that this was growing. We knew that she had worsening pancreatic ductal dilation. So I ended up counseling her for a Whipple, which she did. So intraoperatively, what I'm looking at, and I will tell you that preparing these slides afterwards was super challenging. And I was telling Dr. Ionetti, my partner and good friend, I said, God, what am I going to show? Because I'm not even sure what I'm looking at when I'm looking at it again. It's such a real-time thing. So really what I was showing is the main things I wanted to be on the lookout for was to make sure I was removing all of the cyst, which was very much in the uncinate process and very much was bordering right up against the portal vein and the SMA. So I wanted to remove the entirety of the cyst. So I'm checking here. This is my porta hepatis anatomy. So hepatic artery is coming behind the bile duct here. This is the portal vein. So I'm checking to make sure I have normal anatomy in this location. And then here I'm actually ultrasounding the area of the pancreatic head. So I'm at the position of doing the Whipple procedure where now I've got my hand behind. So my hand is behind the uncinate process of the pancreas. I'm pulling the pancreas towards me as I'm dissecting the uncinate off. So I'm pulling the cystic area out towards me. And you can kind of catch a shadow. One of these pictures has got this big stone. These are my fingers actually underneath. And I'm catching a little shadow of the stone, which is up at the top here. So in this particular case, using ultrasound was useful to make sure that I was really getting the entirety of that cyst removed and taking all of that with us. So on the final pathology, it was in fact a 3.4 centimeter IPMN. It was low grade. The margins were free of tumor, which is fantastic. Patient did really great. She was out of the hospital in probably 5 or 6 days and is doing really well in her follow-up. And clearly that change in the cyst itself was probably leading to chronic pancreatitis. She had a large stone in the head of the pancreas as well. So they saw chronic pancreatitis changes with that. So the ultrasound was helpful both in just defining the normal anatomy, was helpful in making sure I was really pulling that uncinate process over towards me and really seeing all of that cyst get removed. Next one. So this is a little bit of an interesting case here. So 34-year-old female, I have to go back on my slides to make sure I've got everything in here, but 34-year-old African-American female came to see me with significant complaints of left-sided abdominal pain. So she had all of this workup done, which showed a bunch of things. So everybody was in a panic because she's 34 years old. So initially she had a scan back in 2018 and had this little small cyst out here in the tail of the pancreas. I never met her at that time, which is honestly kind of unusual because I feel like they send all this to us. But she was seen, she had an EUS done in 2018, 15 millimeter by 12 millimeter cyst, no mass, not sure if they biopsied it. So now in 2022, oops, I'm not sure, there we go. So now in 2022, this is what she had. So she had findings of an enlarging cyst in the tail of the pancreas. Am I touching something, guys? I'm sorry. No. Okay, so findings of an enlarging cyst in the tail of the pancreas. She also had findings of a left adrenal nodule. She also had findings of multiple liver lesions, which are not showing up well on this image because that wasn't the point of this talk, but I'll move on and basically say that she also had findings of multiple liver lesions as well. Now, the adrenal nodule was fairly stable in size, so that really hadn't changed a lot from the 2018 scan to the 2022 scan. I'm not sure if I'm touching something, so I'm going to try to hold still. Okay, there we go. Well, maybe not. It seems like every time I talk, it starts to flicker again. Anywho, I'll keep going. So the story of this adrenal nodule is she's doing all the endocrine things, getting all the urinalysis, all the biochemical profiles, everything is going on about this adrenal nodule. She had some altered renin-aldosterone ratio, although her blood pressures were normal. Anywho, we were looking at all of that. The liver lesions, there were several, but my interpretation of that was that they were probably hepatic adenomas. And she had been on oral contraceptives for several years. She's slightly obese, but I was more worried about this pancreas lesion. To me, young woman, dead set center of the pancreas, cystic lesion. This is a mucinous cystic neoplasm until proven otherwise. So what was concerning about it, though, was that now the patient's splenic vein was actually out. So it was out at the area distal to this lesion here. Plus, there was an area kind of at the top portion of this lesion that was a little more concerning. And I wasn't sure if it was just some pancreatitis changes associated with the cyst itself, or was it something else? Was it something more solid? So she went and got an EUS as well. Oh, here's her MRI. Great. So I threw that in there too, so that you can see some of these little liver lesions there. I honestly had not much concern that this was a malignancy, but rather was a constellation of symptoms. Because I was worried about the pancreas lesion, though, after we discussed at length about the adrenal nodule and determined that it did not need to come out because it was not active and was also not hormone producing, we elected to proceed with doing a thorough ultrasound of the liver, a liver biopsy to prove that the lesions were not a metastatic cancer, and then to do a distal pancreatectomy and splenectomy. So that was what we did. This is all the stuff they did. There was a big cystic lesion in the body of the pancreas, about 3.5 centimeters, had clearly grown over the past 2-3 years. No path, because on a cystic lesion, there's, oftentimes not going to be path that's going to come back. One thing that was interesting about it, this fluid amylase quite high, the CEA was low, not super high like we would expect for a mucinous lesion. However, the glucose was less than 2. And this has been the more common thing that we're reporting now as it relates to cis fluid workup, is the glucose level. So they did everything else. They did, oh my goodness, all these scans, a CT scan of the chest, an octreotide scan, a PET CT, a brain scan. I mean, everything. She literally had every possible scan that one could imagine. So we get to the operating room. I'm looking around at these liver lesions. And so I'm taking a couple of biopsies of the liver lesions. I send a frozen section of that. That comes back as nothing. So those are probably just hepatocellular adenomas. And then I'm out in the pancreas, and now I'm looking very carefully out in the pancreas to try to figure out what's going on. So I can see the cystic area of the pancreas, but I keep getting hung up on this adrenal nodule, which I can also see. So I'm going back and forth trying to decide if the adrenal nodule is what I'm after or if it's the pancreas cyst, but I can see the cyst. I'm looking at the blood vessels as well, because I'm looking to see where is the splenic artery coming in and where is the portal splenic confluence. So I can see that very well. What I would tell you was concerning to me about this case was I was getting hung up on the fact that even though I couldn't see the splenic vein on ultrasound, I knew it wasn't there from the preoperative imaging. I kept looking for it intraoperatively in the OR because I'm trying to decide if I needed to clip it or staple it or whatnot. Ultimately, I never found a splenic vein, so I just let that go. So we used the ultrasound to help define the borders of what we were planning to resect and make sure that we're removing the entirety of the cyst. So the final path on that, as an FYI, it was indeed a mucinous cystic neoplasm. It was entirely resected. The path was benign on the liver lesions as well. So this is the last case that I have to present. So this is a 47-year-old male who presented with jaundice and pretty significant pruritus. So he had this MRI where you can see that his common bile duct is quite dilated here. He's got one of those big, giant 3-4 centimeter stones within his gallbladder. And then you can see kind of down distally here in the distal common bile duct, he's got a little stone that's enlarged down there. So this patient underwent an ERCP, got the stone taken out, and was being seen by the general surgery service. And something happened where they started panicking, I think, because again, he went through a whole series of modalities. And so he had his I think he had the ERCP. They did a CAT scan as well because, you know, we got an MRI, we should get a CAT scan as well. So you can see this big thickened stone in here, right? We know that that's got to come out because of worrisome for malignancy or precancerous risk. But then they got an ultrasound as well. And the ultrasound is what had everybody all concerned. So on this ultrasound, they were reading that there was a mass in the infundibulum of the gallbladder, something like that. So no mass on CT scan, no mass on MRI, but a mass on the ultrasound. So the general surgery service calls me all in a worry. They're just in a panic about, you know, that there's a mass. And I said, well, I would rather do the case then. So I take the patient and get him set up and do all the appropriate counseling. And maybe we'll have to do lymph nodes and maybe we'll have to do a liver resection and whatnot. So we do all of this. So I used ICG. This was great. I love the ICG for this patient. So it turned out beautifully. Here we're dissecting in here. And here's the common bile duct. It's fluorescing beautifully, so I can see everything that I need to see really, really well. Here I'm getting the ultrasound in so that we can double check the anatomy. This infundibulum of the gallbladder was super socked in. There was a lot of inflammation in this location. So all that inflammation made this dissection right here at the junction between the cystic duct, which you can see very nicely here, and the junction of the common bile duct a little tricky. So in this role, I am always having the fellows ultrasound the porta hepatis because I want to make sure that we're not going to take the right hepatic artery. So we're using the ultrasound to really define the course of the right hepatic artery to make sure that we know exactly where it is and we're not coming into it. So that's really where the ultrasound was super critical and helpful here. So this is our ultrasound pictures that we're seeing. So hepatic artery is up here, portal vein. We're looking at the vena cava. They put a stent in after they took that stone out. So I love having this ultrasound picture that shows me where the stent is. So although I could see it great with the ICG, but having that stent in place is super helpful when you're worried about inflammation from a gallbladder or a mass or a cancer, because I can ultrasound and just know for certain where is the common bile duct. So I can see where the common bile duct is. I can see where that stent is going in place. I can see the right hepatic artery, which is coming behind the stent in this location. So I know in my dissection exactly where I am. So end result was that it was a large stone in the gallbladder. I took it downstairs. I did not find a mass. We opened it up downstairs in pathology, and I did a frozen section. And the final pathology just showed that there was no cancer. So thank goodness. And we did not end up doing a lymphadenectomy or have to do a liver resection at the time. So those are just a couple of uses of intraoperative ultrasound kind of in this setting. And I recognize now that these are all essentially benign cases, but a couple of different applications of how I really think that using ultrasound can be super useful in each of these different scenarios. So I always have my fellows do a laparoscopic ultrasound of every normal gallbladder. And I'll be honest with you, I think that that's a super useful way of being able to laparoscopically get familiar with the porta hepatis, finding where the structures are. And it's just that repetition that lets you be more comfortable with what you're doing so that you can apply it, particularly when you have situations in which things are not normal. So, all right, I will go ahead and pause there. And okay, thank you.
For Dr. Baker. Got plenty of time for questions. Questions for her, for technique. I think that's a really good trip to, you're just learning how to use ultrasound, especially we talked about this in the open station, biliary ultrasound, like I don't know how many people out there do gallbladders, but those of us who teach residents, and fellows, like, just, use the ultrasound on the easy cases, right? Kind of like the same concept as the robot, right? Use a robot and gain your experience on the easy cases. Any questions?
If you find, so if you're doing like a lot of coding, and you think you see a stone, what do you do that next? Do you do an intraoperative cholangiogram?
A stone in the bile duct.
Yeah.
So I would do an intraoperative cholangiogram, and then I would get up at cholecystoscope, the new one that to start trying to see if I can pop it through. And I've used that Boston Scientific scope a couple of times, which is what we have available to us. And so I've done some transambulary dilations and then kind of pushed the stones through. And that's what I've used it for most often. I would say that sometimes I find it can be hard to see a stone that's impacted down distally with ultrasound. So really what I would be interpreting in that scenario is the bile duct dilated that has me worried about that and would prompt a cholangiogram in that scenario. So absolutely. Yes.
Thanks for the talk. Where do you like to put the port for the laparoscopic ultrasound when you're doing that with the gallbladder?
Good question. Most of the time I have a 12 mm port in a supraumbilical or infraumbilical position. Now, the tricky part about that is I think that the best view that you're going to get of the port evidence that's useful to your interpretation, like I showed with that picture, is where you're really looking at a transverse view, right? So you're seeing all of the structures that you know to see, the bile ducts, the hepatic artery, and the portal vein. So from that position, it can be sometimes difficult to get a completely lateral view that's going across. So I'll have to demonstrate that for the fellows a couple of times. The other view is that what I like to do is I mobilize the entire lower 1/3 of the gallbladder away from the cystic plate, because that is my comfort zone in making sure that I know that I have the correct anatomy. Once you've mobilized that lower 1/3 of the gallbladder away, you can sneak your laparoscopic ultrasound in that space to then rotate and show intrahepatically where the right hepatic artery is coming in. So that's my favorite maneuver. And if the fellows accomplish it, I get very happy about that, because then they're really proving to me that the right hepatic artery is still visualized going in and it's not going to be down there at the infundibulum. So that's my favorite way of using it. Obviously, the best and most straightforward approach is to put the 12 mm trocar in the epigastric region. For some people, that also works well, particularly if they end up having to take the cystic duct with, a purple or gold wet clip or with a stapler, because then essentially you're working straight across. I just don't often have time for that, or like to upsize my 5, but I think everybody's a little bit different. Yeah. Any other questions? Okay.
So, Dr. Jensen, Dr. Unity, everybody else who's back there, any places that, specifically in pancreas and biliary, because, my good friend, Dr. J. Raj, always talks about how pancreas ultrasound is the stepchild, of ultrasound to liver. And it kind of is, because I even was speaking to a fellow, and he was telling me, or they were telling me, that, they don't use the ultrasound in all the pancreatic cases. So talk to me a little bit about, like, what's the most useful thing for you, Dr. Jensen? Pancreas ultrasound, most useful.
I think, well, I totally agree, actually. I think mostly what I use it for realistically is just checking tumor location and where I want to be cutting things. When you have neck tumors or tumors that are in that area, I definitely use it just so that I know the vascular anatomy before I eat stage across the major organ. So if I'm going to cut the pancreas and I'm close to the neck, I'm definitely going to be looking where's the celiac trunk, where's the SMA, where's the SMV, spinal vein confluence. That's when it's, I think, the most useful problem. It's just making sure you've got safety before you start firing safety.
Great, thank you. I'm gonna pick on Dr. Visser.
Yeah, I think that the cases you can't do without it are enucleations, for example, right? And the challenge is you're doing it when you want to enucleate something and preserve, like it's an unstable tumor that's a little insulinoma, and you want to see if you can enucleate it and not get into the pancreatic duct. So not only do you have to be facile with the anatomy, but you actually have to be able to see the smallest structures with the best resolution, because this is a couple of millimeters of like, can I nucleate it and not be in pancreatic duct? So you can only do that if you're using it. You won't have confidence that you not only are able to image the pancreatic duct in a non-dilated duct, because it's a person with a pancreatic neurotic, right? So it's a little 12-millimeter neurotic tumor in the uncinate, and you got to see a 2-millimeter pancreatic duct. But you also have to have confidence that you have the spatial resolution understanding of the relationship of that duct to the tumor in 3 dimensions, which only comes with time separate from the ability to actually capture it in a moment, a fleeting moment. You have to have the intuitive understanding of that actual distance in 3 dimensions. So I do think you need to use it very routinely. But, like obviously lots of cases, you're either taking the tail or you're taking the head, and you're going to divide it somewhere around the neck, either way, so that you don't have to use it. That being said, as soon as you have the tail IPMN, you're trying to find the transition, and it's a little later, you want to give her diabetes, so you want to know where that duct goes from a dilated duct to a more normal diameter, so you can still send a frozen to make sure there's no high-grade dysplasia. You have to be able to just say like, well, I could just take it at the neck and take all of the tail of the pancreas, and I'm far away from these. Or I could see where the transition from dilated duct to normal duct is, try to go a little further left, save this little lady a couple more, inches of pancreas, and reduce her chances of post-op diabetes, but also not get right into the middle of the darn tumor. So, I think you do want to be taking it out routinely for those patients pretty often.
Yeah, thank you, Dr. Visser. Thank you, everyone. Yeah, I completely agree with all the points that were made, and thank you, Dr. Visser, for bringing up the point of enucleations and it's like in then you use ultrasound for that. But the classic case, and I agree with Dr. Jensen, margins. We got the tumor right on the neck of the pancreas. Wow, do I come from the right? Do I come from the left? Ultrasound is so key to be able to make sure that you're getting yourself a good margin and helping you make that decision. So, great. Any last questions?
No, thank you very much. It's kind of exciting to show this, and I think that we do a lot of ultrasound every single case to make sure the ultrasound is open, and I think it's just as important for trying to look at abnormal anatomy, but really the key is making sure that you have a good understanding of what normal anatomy looks like, so that you can set yourself up for success on those cases that are going to be difficult. So on this gallbladder case, I'll be honest with you, I mean, it's a challenging gallbladder, but at the same time, being confident of knowing where structures are and being able to look at everything very carefully is what makes this be a safe operation. And that's what sets this patient up for a good outcome. And if this was a cancer, I would have used the ultrasound to help find the structures to do an appropriate laparoscopic lymphadenectomy to be able to get all of those nodes out from kind of do my liver resection and kind of guide the resection of the portions of the gallbladder fossa as well. Fortunately, it was not a malignancy, so that was great for the patient, but can be useful in a lot of different scenarios in that type of a case.
Dr. Jensen's point about before you fire a stapler, I think the place you're going to maybe want to use that at times is with the invasive pancreatectomy. Like you guys are the generation, you have to do these invasive stapler. So like that's that origin, right? The splenic artery sometimes goes right before it goes left. For the hepatic artery, like say, right, little old people who need those arteries are squiggly. There will be a day you're doing an invasive pancreatectomy that you're going to have a momentary panic. You just took out the celiac trunk or the hepatic artery because you were a little further right or left than you thought. And literally, you're going to be like, oh my gosh, you can't figure it out unless you can ultrasound know if you get out or not. You can have a little bit of pulse in the hepatic artery that's coming from the GDA, but you just took the whole celiac trunk. And then you're going to come across it the second time somewhere to the right, and you're going to be like, and not knowing. So like when you get facile with the anatomy, also knows, like you get facile with the anatomy, then you're going to also be able to reassure yourself, or figure out if you did something bad with a stapler.
Great. Okay. Thank you. Thank you so much for your comments. Thank you, Dr. Baker. So our next case presentation is going to come from my good friend, Dr. Eric Jensen, who is associate professor of surgery at University of Minnesota. And he's going to show us some cases on the grandfather, yes, right? On the stepfather, on liver. So thank you so much, Dr. Jensen.
This is meant to be interactive, so we can talk about anything you guys want to talk about. I guess I'll make a couple comments too that I didn't want to shout from the back, but if you don't have a cholecystoscope, it doesn't matter. You can use a ureteroscope. Actually, at our hospital, the ureteroscopes have way better resolution, so I just found that out last week when I needed one. So I'm gonna use theirs from now on. And I just want to expand on one thing Dr. Visser said too, which is when you're looking at pancreatic anatomy, and you're looking for a tiny duct. You got to be very careful to have a light touch on the pancreas when you're using ultrasound, because if you put really much pressure at all, you'll suppress the duct. It makes it really hard to see. So that's a time I think some of us maybe talked about in the room too, where having some saline in there or having a little bit of a, some people call it a standoff approach, where you put some water on it and have the ultrasound either a very light touch or even floating in the pool is sometimes a good way to try to figure that out if you're looking for a really tiny duct. So like I said, we can talk about whatever you want. But when it comes to liver surgery, I hate to say, but I did not prepare any like open surgical using ultrasound to plan my transection line or things like that, which actually is something we always do. And I would also say something just to add on what Dr. Baker said at the end. Any pancreas and liver case that we do, automatically the ultrasound is on that cars. And I might just recommend that everybody do that actually, because if you think to yourself during the case, oh, I should ultrasound this, but then it's 20 minutes for someone to run around and get it, you're going to just say, ask for it. But if the ultrasound is there waiting every case you do, it's very easy to say, hey, let me do the ultrasound real quick. We're just going to run the anatomy. So I would encourage everybody to just have the ultrasound for any pancreas and liver case. To me, it's a good idea. So I was just going to show a case of what I use ultrasound a lot for, which is targeting. And those of you who are going to do an ablation course later today, I'm not going to spoil any big surprises. But I think there's some good stuff. How many of you are doing the ablation course also? Okay. So some of this, I mean, pay attention back there. So this, for some of you, you're going to hear more of this later from my colleagues. But for those of you who are not taking, this is sort of touching on just using ultrasound for guidance and in my view, some easy ways to basically help yourself be successful. Videos that we can look at the end. And obviously in the stop. This is basically a young person with multifocal liver mets from a colorectal cancer. Oh, the pointer button makes me go backward. Let's look at pointer on this. Okay. Well, I'll point with my finger. So there's a small one here. There's one over here. There's one in the deep right. There's one in the back. There's another one here. So they're just kind of scattered. And this, I actually don't remember anymore because I put this together in kind of haste. These are probably resectable with a little combination of lateral left and a little bit larger resection on the right. But in this case, we were ablating them all. And I just want to show a simple setup that we kind of talked about in the room next door earlier. But when it comes to treating lesions like this, one of the ways I think you're going to be successful, which has been touched on already, is if you try to do the same thing every time. So when you're doing a liver, if you pull out the ultrasound and you run through the anatomy in the same way every time, that helps you figure out what's normal, what's variant. Really quickly, you can pick out variants because you're used to seeing what a normal thing looks like. Same with pancreas, not to diminish the ugly stepchild. But for me, with ultrasound of the liver, I do it the same way every time. And actually, this was just mentioned as well. I have the ultrasound coming from the right flank. And I do that because of what this picture shows, which is I'm going to show a series of images. And I have, these are movies too, but I can't control them with a keyboard here. So it's going to be a little bit screwed up. But with this setup, you can basically hit any segment of the liver, any part of the liver. This setup will allow you to treat it. I always have the ultrasound coming from the right. It's angled so I can get the needle under it if I'm targeting something. And I'll just see, I'm not sure. We'll see if these, how do I get a video to play? Because I don't have a separate, is there?
Yeah, it keeps, okay, well, we'll watch this video instead. So with ultrasound, if you're looking at anatomy, that's one thing. You can hold the ultrasound in sort of a sagittal or axial position, depending on what you're looking for. When you're targeting something, I think it's most useful to, and you're going to see some techniques from experts that are going to be teaching this a little later today. But having the ultrasound probe in a way that the needle is parallel to it. If you have a camera looking at your ultrasound and you have the camera looking directly at the transducer, and you can see the tumor, which is this thing here, with that same transducer, then you know the tumor is on the line between your camera and the ultrasound. Very simple. And then you just drop the needle on that line, and all you have to adjust for is depth. These are real time, not edited, so you can see how long it takes. I didn't try to make it really pretty. You can see I'm moving the needle around and things. But basically the principle of it is using ultrasound to identify the needle. So you can see the tip of my needle, you can see the target. And in this case, the nice thing about ultrasound is you can really see well in most cases. It's hard if somebody's got steatosis, real fatty livers, small tumors. That makes it a lot harder because the liver is more echogenic. But for a normal standard, the anatomy that you can see with the liver is super clear, super good. A comment about ablation too, for those of you who aren't taking the course later, I generally try to avoid like poking a tumor and then saying, oh darn, that's not in the middle, and then backing it up and poking it again. That's really bad form. So ideally, you might have noticed on that video, you stop just before the tumor, figure out, make sure you're really where you want to be, and then hit it. Ideally, you hit it once and that's it, and then we burn it so that you're not tracking tumor cells all over the place. So same setup, different tumor. And we don't have to run through all this because you're going to get the point, right? Same setup, different tumor. This is a little bit, in the posterior 6/7, same idea. I'm not going to go through every one because we kind of talked about this. You can burn, obviously, larger tumors. This is obviously an MRI of a person. This person had multiple tumors, but this was the most problematic of them. Sitting on the right vein, essentially just adjacent to the vena cava. Somebody asked earlier, can you burn around major vessels? And the answer is yes, can. This is an example of that. This is a pretty big tumor. The particular device we use multiple probes. So in this case, we use 3 just because of the size of this, but this is the new wave device for those of you who are interested. It's in the other room there, but other devices can do the same thing with fewer probes. I'm not going to go through these videos, but just to show again how I hope these lights aren't screwing it up. Can you guys see that well? The tumor relationship to the, we're just going to click through all these with the needle. Can you see the tumor? Okay. Yeah, it's pretty clear, but with the lights here, I'm not sure. But anyway, the nice thing about ultrasound, like I said, is it's especially when you have an ultrasound sitting on a liver, you can see not only all the critical anatomy, but anything you want to target. I don't know if I want to talk too much about technique because there's a course coming up in this, but what you notice on this particular panel is like if you're burning a larger lesion or something that's an irregular shape, you can use more than one probe. And once you have a single probe in the lesion, it's very easy to hit a lesion. You already have a reference, right? So once there's one needle in a tumor, it's really simple to put the needle parallel to it. How hard is that, right? So adding an extra needle or two doesn't really change it.
Is that better, everybody?
Yeah.
Okay, good. Yes, that's good. Thank you. Sorry to interrupt.
I should have maybe done this in reverse because I'm showing this and then my last one. So you can see we did a pretty big burn, and I was joking with some of the people that came through. Came through our station, but Dr. Iannini is very passionate about the fact that surgeons are better at bleeding things than radiologists, interventional radiologists. And I think one of the reasons is we're just more aggressive. So you can see that's not a small burn for the type 2 we did. This person did not get a hepatic vein thrombus, but I mentioned to a couple of people coming through, this is a technical issue when I burn around large, particularly the hepatic veins. I do put people on prophylactic Lovenox after, because I have had a few people over the years that have had hepatic vein thrombus. And it might be moving to put them on prophylaxis after you just burn a giant hole in your liver, but that's what I do. So you can see, we can be pretty aggressive. The other nice thing about ultrasound is you can get everywhere in the liver very easily, which is another advantage for surgeons relative to IR. So they're either using sometimes a scanner or an MRI. For us, we can put an ultrasound any part of the liver. So these are just sort of examples. If you're working on the low liver, segment 5, and you need to burn something, you can actually just flip your ultrasound upside down. See it that way if you want to target something where you have a needle coming in front of it. So it still allows you to have a needle that's parallel to your transducer as you advance towards the tumor. Same thing, that's just looking up over the dome, sort of medial segment 8/7. Same thing on like 4B. If you're doing segment 7, you can mobilize the right lobe. I think I mentioned to a few of you, most of these are like 3-port cases, very simple. A port umbilicus, a port in the right flank for the ultrasound. You notice also the ultrasound, we're talking about different areas of the liver. The ultrasound is the same every time. So always the ultrasound, in my case, it's always the ultrasound is coming from the right. If you're doing a high 7 way in the back and you need to get it off the diaphragm, I'll add a third port that comes from the patient's left. So there's a little retractor coming across the liver and holding the lobe up. So we can do all our mobilization through a single port in the right flank. And then we just have a needle hole, ultrasound, needle hole, camera, retractor. So just some setup things. You're going to get more details about this later. But again, with that setup, this is just showing lateral segment. Easy to get an ultrasound over there from all the same setup.